CEN Certification Study Guide. Question 1. A patient presents with a severe headache, nausea, and vomiting. The patient has a history of hypertension. Which finding would suggest a subarachnoid hemorrhage? Option A. A sudden, severe headache, thunderclap, and nuchal rigidity. Option B. Gradual onset headache. Option C. Blurred vision and photophobia. Option D. Focal neurological deficits. The correct answer is option A. A sudden, severe headache, thunderclap, and nuchal rigidity. Subarachnoid hemorrhage presents with a sudden, severe thunderclap headache, often described as the worst headache of my life. Nuchal rigidity, neck stiffness, is a classic finding. CT head is the initial diagnostic test. Gradual onset suggests a different etiology, e.g., migraine. Focal deficits may suggest an ischemic stroke or mass lesion. Question 2. A patient presents with a peritonsillar abscess with a hot potato voice, trismus, and drooling. What is the priority? Option A. 4 antibiotics. Option B. And consult for possible incision and drainage. Option C. Steroids. Option D. CT scan of the neck. The correct answer is option B. And consult for possible incision and drainage. A peritonsillar abscess presents with a muffled hot potato voice, trismus, difficulty opening the mouth, drooling, and a unilateral bulging tonsil. It requires prompt evaluation for possible incision and drainage, IND, or needle aspiration. 4 antibiotics and steroids are adjuncts. Airway compromise is a risk, so airway management is the priority. A CT scan may be done to confirm the diagnosis but should not delay end consultation. Question 3. A patient with sepsis has a MAP of 55 mmHg despite fluid resuscitation. The CEN should anticipate which vasopressor? Option A. Dopamine. Option B. Norepinephrine. Option C. Phenylephrine. Option D. Epinephrine. The correct answer is option B. Norepinephrine. Norepinephrine is the first-line vasopressor for septic shock. It increases MAP through vasoconstriction and is preferred over dopamine due to a better safety profile. The sepsis protocol recommends early broad-spectrum antibiotics, within 1 hour, 30 ml/kg crystalloid, and vasopressors for fluid refractory shock. MAP target is 65 mmHg. Question 4. A patient presents with a chemical splash to the eye. The CEN should: Option A. Neutralize the chemical with a buffer. Option B. Irrigate the eye continuously until pH is neutral. Option C. Patch the eye and refer to ophthalmology. Option D. Administer antibiotics. The correct answer is option B. Irrigate the eye continuously until pH is neutral. Chemical eye injuries require immediate and continuous irrigation with normal saline or lactated Ringer's solution until the pH of the eye is neutral, pH 7.0. Alkali burns are more damaging than acid burns and require extended irrigation. Irrigation should begin immediately and continue for at least 15 to 30 minutes. For severe alkali burns, it may take hours. Antibiotics and patching may be used after irrigation. Question 5. A patient with a suspected pneumothorax has unilateral decreased breath sounds and tracheal deviation. The CEN should: Option A. Administer supplemental oxygen. Option B. Prepare for needle decompression. Option C. Obtain a chest X-ray. Option D. Place the patient in a supine position. The correct answer is option B. Prepare for needle decompression. Tracheal deviation with decreased breath sounds suggests attention pneumothorax, a life-threatening emergency requiring immediate needle decompression. Oxygen is given but does not treat the underlying pathology. Chest X-ray should not delay treatment. The patient should be positioned upright if possible. A supine position can make the diagnosis more difficult. Question 6. A patient presents with a sudden onset of a severe headache, nuchal rigidity, and photophobia. The CEN should suspect. Option A, meningitis. Option B, subarachnoid hemorrhage. Option C, migraine. Option D, both A and B. The correct answer is option D, both A and B. Meningitis and subarachnoid hemorrhage share classic signs: severe headache, nuchal rigidity, and photophobia. The differentiation is made with imaging, CT for SAH, and lumbar puncture, LP for meningitis. Treatment for both is emergent. A non-contrast CT head is often the first test for SAH, LP is used for meningitis and if CT is negative for SAH. Question 7. A patient with thyroid storm presents with fever, tachycardia, and confusion. Which medication is used to reduce thyroid hormone levels? Option A, propylthia uracil, PTU. Option B, methimazole. Option C, propranolol. Option D, all of the above. The correct answer is option D, all of the above. Thyroid storm is managed with medications that block thyroid hormone synthesis, PTU or methimazole, and beta blockers, propranolol, to control symptoms, tachycardia, tremors, hyperthermia. PTU is preferred because it also blocks the conversion of T4 to T3. Cooling, 4 fluids, and dexamethasone are adjuncts. The CEN should anticipate ICU care for these patients. Question 8. A patient with pulmonary embolism has a Wells score of 6. What is the most appropriate diagnostic test? Option A, D-dimer. Option B, CT pulmonary angiography, CTA. Option C, V/Q scan. Option D, chest X-ray. The correct answer is option B, CT pulmonary angiography, CTA. In patients with a high pre-test probability for PE, Wells score 4, CTA is the diagnostic test of choice due to its high sensitivity and specificity. D-dimer is useful in low probability patients to rule out PE but has low specificity. V/Q scan may be used if CTA is contraindicated, e.g., renal failure. Chest X-ray may show other causes but is not diagnostic for PE. Question 9. A patient with a spinal cord injury at the C5 level is experiencing neurogenic shock. Which findings are consistent with this? Option A, hypotension, bradycardia, and warm, dry skin. Option B, hypertension, tachycardia, and cool, clammy skin. Option C, hypotension, tachycardia, and warm, dry skin. Option D, hypertension, bradycardia, and cool, clammy skin. The correct answer is option A, hypotension, bradycardia, and warm, dry skin. Neurogenic shock results from loss of sympathetic tone following spinal cord injury above T6, leading to unopposed parasympathetic tone. This causes hypotension, bradycardia, and warm, dry skin, vasodilation. This is in contrast to hypovolemic shock, cold, clammy, tachycardia, and cardiogenic shock. Treatment includes 4 fluids and vasopressors. Question 10. A patient has a suspected tension pneumothorax with tracheal deviation, unilateral absent breath sounds, and hypotension. What is the priority intervention? Option A, chest X-ray. Option B, needle decompression. Option C, chest tube insertion. Option D, oxygen therapy. The correct answer is option B, needle decompression. Tension pneumothorax is a life-threatening emergency requiring immediate needle decompression, second intercostal space, mid-clavicular line, or finger thoracostomy. The condition causes mediastinal shift, impaired venous return, and shock. Chest X-ray should not delay treatment. Chest tube insertion follows needle decompression. Oxygen is adjunctive but not the priority. Question 11. A patient with DKA, diabetic ketoacidosis, has a blood glucose of 500 mg/dl, pH 7.2, and bicarbonate 14 milliequivalent/L. The CEN should anticipate. Option A for insulin bolus. Option B for normal saline and insulin drip. Option C bicarbonate infusion. Option D potassium replacement. The correct answer is option B. For normal saline and insulin drip. DKA management includes for normal saline fluid resuscitation, continuous for insulin infusion, and monitoring of electrolytes, especially potassium. Bicarbonate is not routinely recommended unless pH 7.0. Potassium depletion is common and should be monitored and replaced before insulin treatment, as insulin drives potassium into cells. Insulin is given as a continuous drip, not a bolus. Question 12. A patient with renal failure presents with fluid overload, dyspnea, and hypertension. Which intervention is a priority? Option A hemodialysis. Option B for furosemide. Option C for nitroglycerin. Option D. All of the above. The correct answer is option D. All of the above. The management of renal failure with fluid overload includes for furosemide to remove fluid, nitroglycerin or other vasodilators to reduce afterload, and hemodialysis if the patient is not responsive to these measures. Dialysis may be needed for severe hyperkalemia, refractory fluid overload, or uremic symptoms. Acidosis may also require bicarbonate. Question 13. A patient with a suspected myocardial infarction has a cardiac arrest. The ECG shows ventricular fibrillation. After the first defibrillation attempt, what is the next step? Option A resume CPR immediately for 2 minutes. Option B administer epinephrine 1 mg for. Option C administer amiodarone 300 mg for. Option D check a pulse. The correct answer is option A. Resume CPR immediately for 2 minutes. After defibrillation for VF/pulseless VT, the ACLS algorithm directs an immediate return to CPR for 2 minutes, 5 cycles, before checking the rhythm and pulse. Epinephrine is given after the second shock. Amiodarone is given after the third shock. High-quality CPR is essential for outcomes. Question 14. A patient with a history of opioid use disorder presents with respiratory depression and constricted pupils. Which medication should the CEN anticipate? Option A naloxone, Narcan, 0.4 mg for. Option B flumazenol, Romazicon. Option C naltrexone. Option D buprenorphine. The correct answer is option A. Naloxone, Narcan, 0.4 mg for. Naloxone is the opioid antagonist used to reverse opioid overdose, which presents with respiratory depression, pinpoint pupils, and decreased consciousness. The dose may be repeated if there is no response. Flumazenol is for benzodiazepine overdose. Naltrexone and buprenorphine are used for maintenance therapy, not reversal. Airway management is the priority. Question 15. Which finding in a patient with asthma exacerbation indicates life-threatening status asthmaticus? Option A wheezing. Option B silent chest. Option C peak expiratory flow rate, PEFR, 70% predicted. Option D cough. The correct answer is option B. Silent chest. A silent chest on auscultation in a patient with severe asthma indicates minimal air movement and impending respiratory failure. This is a life-threatening sign requiring immediate intubation and mechanical ventilation. Other indicators include confusion, exhaustion, PEFR 33% of predicted, and SpO2 90%. Question 16. A patient has a cut from a knife that is 2 cm deep and located on the palm of the hand. The CEN should. Option A irrigate and suture the wound. Option B check for tendon and nerve function. Option C apply a pressure bandage. Option D administer antibiotics. The correct answer is option B. Check for tendon and nerve function. Deep lacerations on the palm are at high risk for tendon or nerve injury. A thorough neurological and functional assessment is essential to identify any deficits. The wound should be irrigated and may be sutured, but only after the assessment. Antibiotics are not routinely given for wounds unless infected or high risk, animal bites. Pressure bandages are for bleeding control. Question 17. What is the Glasgow Coma Scale, GCS, score for a patient who opens eyes to pain, makes incomprehensible sounds, and has abnormal flexion, decorticate, posturing? Option A 10, E2V2M4. Option B 8, E2V2M3. Option C 7, E2V2M3. Option D 9, E3V2M4. The correct answer is option C. 7, E2V2M3. GCS assesses eye opening, E2 to pain, verbal response, V2 incomprehensible sounds, and motor response, M3 abnormal flexion/decorticate. 2 plus 2 plus 3 equals 7. A GCS 8 generally indicates the need for airway management, intubation. GCS is used to monitor neurological status in patients with head injury or stroke. Question 18. A patient presents with a foreign body sensation in the eye, tearing, and photophobia. The CEN should: Option A use a slit lamp to examine the eye. Option B perform fluorescein staining and a slit lamp exam. Option C irrigate the eye. Option D: all of the above. The correct answer is option D: all of the above. A corneal foreign body or abrasion requires a thorough examination under a slit lamp with fluorescein staining to identify the location and extent of the injury. Irrigation may be needed to remove loose foreign bodies. The CEN should identify and remove the foreign body if visible or refer to ophthalmology for removal. Antibiotics are often prescribed. Question 19. A patient with heart failure presents with severe dyspnea, pink frothy sputum, and rales auscultated halfway up the lung fields. The CEN should anticipate which intervention? Option A 4 normal saline bolus. Option B 4 furosemide and nitroglycerin. Option C 4 epinephrine. Option D immediate intubation. The correct answer is option B. 4 furosemide and nitroglycerin. This patient is in acute decompensated heart failure with pulmonary edema. Management includes diuresis, furosemide, and afterload reduction, nitroglycerin, to reduce preload and afterload. Oxygen and non-invasive positive pressure ventilation, BiPAP/CPAP, may also be used. Normal saline would worsen volume overload. Intubation may be needed if the patient fails non-invasive measures. Question 20. A patient who is depressed and suicidal is admitted to the ED. The CEN should: Option A ask the patient if they have a plan to harm themselves. Option B avoid asking about suicide to prevent giving the patient ideas. Option C ask the patient only about feelings of hopelessness. Option D ask the patient about their mood. The correct answer is option A. Ask the patient if they have a plan to harm themselves. Asking about suicidal ideation and a specific plan is essential for risk assessment. It does not give the patient ideas but helps the healthcare team determine the level of risk and implement appropriate safety measures. Direct, non-judgmental questioning is recommended. Evaluation of intent, plan, and means is critical in assessing suicide risk. Question 21. A patient presents with testicular pain, dysuria, and a fever. The testicle is tender. Which diagnosis is most likely? Option A testicular torsion. Option B epididymitis. Option C orchitis. Option D hydrocele. The correct answer is option B. Epididymitis. Epididymitis is inflammation of the epididymis, often due to infection, UTI, ST. It presents with gradual onset of testicular pain, swelling, tenderness, fever, and sometimes dysuria. It is differentiated from torsion by gradual onset, versus sudden, and presence of fever. Doppler ultrasound shows increased blood flow in epididymitis, versus decreased in torsion. Treatment includes antibiotics and NSAIDs. Question 22. A patient with a stroke is within the 4.5-hour window for TPA. The CEN should: Option A. Obtain a CT head to rule out hemorrhage. Option B. Check the blood pressure, target 185/110 mmHg. Option C. Prepare for TPA administration. Option D. All of the above. The correct answer is option D. All of the above. TPA is indicated for acute ischemic stroke within 4.5 hours of onset. The protocol includes CT head to rule out hemorrhage, blood pressure control, 185/110 mmHg, and preparation for TPA administration. If the patient is a candidate, TPA is given, and the patient is monitored in a stroke unit. Question 23. A patient with status epilepticus has received lorazepam 4 mg for without cessation of seizure activity. The CEN should anticipate which next medication? Option A. Phenytoin 20 mg/kg4. Option B. Propofol 20 mg/kg4. Option C. Valproic acid 20 mg/kg4. Option D. Levetiracetam, Keppra, 1 gram/4. The correct answer is option A. Phenytoin 20 mg/kg4. After benzodiazepines, lorazepam, second-line agents include phenytoin, 20 mg/kg4, or fosphenytoin. Levetiracetam and valproic acid are also options but may be considered after phenytoin. Propofol is used for refractory status epilepticus. Airway management is critical, the patient may require intubation. Question 24. A patient presents with severe crushing chest pain. The ECG shows ST segment depression and T-wave inversion in leads 2, 3, and AVF. This is most consistent with Option A. Anterolateral STEMI. Option B. Inferior STEMI. Option C. Non-ST elevation myocardial infarction, NSTEMI. Option D. Pericarditis. The correct answer is option C. Non-ST elevation myocardial infarction, NSTEMI. ST segment depression and T-wave inversion without ST elevation indicate NSTEMI, or unstable angina. Inferior leads, 2, 3, AVF, show ischemic changes. NSTEMI management includes antiplatelet therapy, aspirin, ticagrelor, anticoagulation, and possible PCI depending on risk stratification, Grace score. STEMI requires emergent reperfusion, while NSTEMI is managed with a more nuanced approach. Question 25. A patient with a known abdominal aortic aneurysm, AAA, presents with sudden onset of severe back pain and hypotension. What is the priority action? Option A. Obtain a stat abdominal CT. Option B. Prepare for emergent surgical repair. Option C. Administer 4 fluids to restore blood pressure. Option D. Obtain a 12-lead ECG. The correct answer is option B. Prepare for emergent surgical repair. Sudden back pain and hypotension in a patient with a known AAA is a ruptured AAA until proven otherwise. This is a surgical emergency. Immediate surgical consultation is the priority. CT may confirm but should not delay surgical preparation. 4 fluids should be given cautiously, permissive hypotension, to avoid increasing bleeding before surgical control. ECG is not the priority.